Good morning. My name is Sheila Pires. Apparently I have a lot going on in my head, although what Gary didn't tell you is it's not necessarily relevant to our discussion this morning. Going almost last, inevitably you're going to touch upon some themes that others have come up with. I want to just say one thing. We can't create a different future if we keep doing what we've done in the past that's problematic. So I want to return to a theme that I was talking about earlier and maybe be a little bit more specific. States and communities have to stop spending 60 or 70% of their dollars on residential treatment. There is very little evidence of effectiveness around residential care, and there are huge disproportionalities in who ends up in residential treatment. There's an overrepresentation of children and youth of color. There is a huge overrepresentation of children and youth who are involved in child welfare and juvenile justice, and we use those services with a placement mentality, not an active treatment mentality. It's virtually impossible because dollars in our system today are relatively finite. That could change if the advocacy movement that I was talking about happens over time, but right now they're pretty finite. So how can you create sufficient home and community-based service capacity? How can you broaden access to even existing home and community-based service capacity if 60 or 70% of your dollars are going into residential care? So that has to change. States and communities also, and let me just mention one other thing. I don't think it takes 10 to 15 years to redirect dollars now going into residential treatment into home and community-based services. It didn't take Milwaukee that long. There are a number of other states that are engaged in that kind of effort. I do think it will take 10 to 15 years for the country as a whole to change that dynamic, but we better start now. States and communities also have to stop spending 10 to 15% of their dollars, an additional 10 to 15%, buying psychological and psychiatric evaluations and assessments, particularly for children involved in child welfare and juvenile justice systems that never lead to individualized, strengths-based individual care. We're spending enormous amounts of dollars on those kinds of trying to nail a diagnosis instead of working with families and natural helping networks in communities and the youth themselves in order to come up with individualized services and supports that make sense and around which there is evidence. I want to return also to a theme that Sandra Spencer raised around private insurance, and I agree with her fully on the issue of parity, but I think it's also a bigger issue. We need to do much more with the private insurance sector about the types of home and community-based services around which there are cost benefits that they ought to be covering. Minnesota is one of the few states I know of that's engaged now in a public-private partnership in order to articulate a model benefit that's all geared toward home and community-based services, working with private insurers and the large corporations that self-insure. Until we do that, families will continue to have to move to the public system in order to get appropriate services, hopefully, and relinquish custody to access services often, as Sandra said. That's bad for families, and it's bad for the public system, which is already overtaxed. So we need to change that dynamic. There are many other things that could be raised, but those are two in the financing arena. The very third, which I'll throw in, is we have to stop the erosion of Medicaid. That is huge for families that do depend on Medicaid and, frankly, the state children's health insurance program as well. So I'll leave you with that. Thanks very much.